The topic which Dr. Ulas wanted me to talk about is about endocavitary VT ablation, especially about papillary muscle, my approach and the problems we encounter during mapping and the challenges we have during ablation of these tachycardia. I wanted to give this talk as the first one because the papillary muscle VT I'm doing this afternoon, I wanted to set the stage to say that this is one of the tough ones, and we'll see what we can do to try and get rid of this PVC. So the papillary muscles, one second. Premature ventricular complexes, in addition to causing potentially debilitating symptoms, can cause significant LV dysfunction. Multiple single-center studies have shown that catheter ablation is often an effective technique for curing these. However, catheter ablation of PVCs coming from endocavitary structures such as papillary muscle is often challenging, and the results are not as good as compared to PVCs from other locations. Shown in this slide is the pooled data from 8 different centers. The green bar in the line curve represents the papillary muscle cases, and do we have I can use shown here in the green bar is the papillary muscle cases. And as you can see, the acute success can be somewhere around 80% to start with. However, in the long-term data, the results are sobering and often requires use of antiarrhythmic medication to get a reasonable outcome. In addition, the procedure time, the fluoroscopy time, and the total ablation time for the papillary muscle VT cases is significantly greater when you compare from other, or highlighting the challenges which are involved in the management of these arrhythmias. Whenever we talk about the endocavitary structures and about the ablations, we basically are trying to address about different structures which are seen in the endocavitary structures. In posterior left ventricle, we talk about the posteromedial papillary muscle, lateral left ventricle, anterolateral papillary muscle, on the septal RV, moderator and anterior papillary muscle, and in outflow tract region, the septomarginal trabeculations, anterior and posterior, and as well as the conus papillary muscle, which are seen. So these are the structures we talk about when we discuss and talk about the endocavitary structures and the ablation approach. The papillary muscles of the heart are complex intracavitary structures. Their shape, their size can be highly variable, and so is the endocardial vasculature and the Purkinje network conduction system. Anatomically, papillary muscles are the thickest myocardial structures in the heart and comprise a complex of myocardial strands with some separation between them at the basal and the apical side. This most likely results into the anisotropic conduction what we see. And the anatomic variation definitely have a considerable influence on the arrhythmias and the changes which are seen during ablation of these papillary muscle PVCs. One of the distinct electrocardiographic changes what we find in papillary muscle PVCs are that these PVCs often have multiple QRS morphologies with a subtle but a distinguishable difference seen either spontaneously or after initial ablation lesion. Now, this could be either because of the single origin with preferential conduction or variable exits. The other challenges in mapping and ablation of these PVCs are, number one, the difficulty of maintaining a stability of the catheter. Now, this might be in spite of the real-time imaging using intracardiac echo, and as you can see, it is challenging to try and have catheter in the stable location to be able to provide an effective lesion at that spot. Additionally, considering papillary muscles are such a thick myocardial structure, these PVCs might be deep intramural in origin with a variable exit. And therefore, it is difficult to try and penetrate and get your lesions deep enough to provide the effective lesions, or it might actually be coming from the epicardial part of that papillary muscle, and you often in those cases will have to go to epicardium to provide an effective ablation lesion, and therefore the ablation can be challenging. More so when you're doing a mapping of these PVCs, it is difficult to know what is a local EGM versus what is a far field, really, because it all depends where in the intramural part these PVCs are coming from, and therefore the mapping as well as ablation of these premature ventricular complexes are very challenging. Now, this could explain, therefore, that while activation map is the most reliable method of mapping for most of these cases, the variable intramural location and depth of the origin of these PVCs and the variable exit, what we see, can explain the controversies which exist in the pre-potentials and the Purkinje potentials during the activation map. And this is why different body of school thoughts have talked about utility of these ventricular pre-potentials and Purkinje potentials seen at the spot where this ablation was successful. Some centers found and others did not. Similarly, this could also explain why the site with an excellent pace map may fail to eliminate these PVCs. And then often there is a change in the QRS morphology seen with post-ablation, and multiple further lesions are required to try and suppress them. In cases where there is changing morphology, recent work from Yamada and group colleagues have looked at the latency post-pacing, and they found that ablations were often successful at sites with pace mapping and latency. So if you see here, this is quite interesting. So first of all, it is not necessary that if you get a good pace map, you'll be able to be successful and often require multiple lesions. Additionally, so say if you have applied the first lesion and you found that the morphology has slightly changed and you have not been successful, most likely you are trying to modify the variable exit rather than actually at the site where it's coming from. And so say, look at this one, where the real origin was really from here, and you ablated here and you have blocked the preferential exit, and exit is now from a different spot. So to identify that the real site of origin is here, if you pace there, it will take this long to exit. You'll have a perfect pace match with a latency. And therefore, an ablation at the spot where there is a good pace match with latency, your ablation strategy might be more successful in those spots rather than the spots where you just got the good pace map. And with maybe you're not getting a good latency. Those are really most important in cases where you have variable and changing morphology seen post-ablation. In fact, various isolated factors have been identified in previous series to predict outcome. Electrocardiographic features such as pleomorphic PVC, electrophysiological parameters such as activation time, pace map, QS morphology, procedural time. That means spend more time, you'll be able to be more successful. That just highlights the pain involved in ablation of these PVCs. The imaging characteristics such as papillary muscle size and the lesion volume all have been shown as a predictor of success. So, when we are trying to solve this puzzle of how to be successful when you are ablating a papillary muscle PVC, there are some important seminal steps. The foremost among them is the pre-procedural care. Decision about what type of anesthesia to be used, what type of antiarrhythmic patient has been on. Some of these papillary muscle PVCs are cholinergic or sympathetic dependent, and therefore trying to give certain type of anesthesia might suppress these PVCs, and you will not be able to do an activation map, which is most important when you're mapping these cases. Antiarrhythmic medication, and our centers, we normally will stop oral antiarrhythmic for at least 5 days. And if they are on IV antiarrhythmic medications, we'll at least have 12 hours before we'll take them into lab. It's again important to review the 12-lead ECGs and Holter. Most importantly, to try and pick up those changes which can guide you whether this is going to be a challenging case. And I'm going to show what ECG changes such are those seen. 12-lead Holters, if you see a variable exit, a slight change in morphology with these PVC, you are up for a battle, because those are the patients will have preferential exit, multiple exit, and you're going to spend a lot of time to try and eliminate those PVCs. It's important to try and look at the imaging to understand the substrate which is behind these. Are they scar-related PVC? That means, is there any scar present where these papillary muscles are? Or they are just the idiopathic cases. Using CT and MRI to understand the morphology, location is extremely critical, and I'm going to show the examples later on. The use of intracardiac echo, in my personal opinion, is absolutely critical. These are structures which are intracavitary. They are moving to try and have a good stability to understand your catheter is in contact and is in contact with the right tissue. It is extremely important that you have a real-time imaging to be able to ascertain that you are in contact with the tissue of interest. Previous heart surgeries is again very important to know, especially if you are deciding you want to go epicardial, whether you'll be able to go epicardial in those cases or not. Using different mapping technologies, 3D mapping, activation and pace mapping, we have alluded to already. And use of a force sensing catheter is one of the most important tool again to understand that you have enough contact with the tissue which you are trying to eliminate. So let's look at the 12 lead ECGs. We all know these: anterolateral papillary muscle, posteromedial papillary muscle, and RV papillary muscle. Anterolateral papillary muscles, you will have, most importantly, in your right bundle morphology, variable exit, anything from V3 to V4 can be, when you see this transition, you normally will have an inferior axis. Anterolateral papillary muscle classically can have inferior lead discordance. So lead 2 not necessarily will always be inferior lead, can be a small R wave followed by S wave. And generally, depending on whether this is a septal exit versus a lateral exit, the lead 1 can be purely positive or negative. Generally speaking, they are more negative because these papillary muscle PVC, these anterolateral papillary muscle PVCs generally have a lateral exit. When we talk about posteromedial papillary muscle, again, they are always right bundle to start with. They will have transitions somewhere around V3 or V4 or V5 in the precordial leads. They're always superiorly directed. They do not generally have inferior lead discordance. And where the exited, whether this is a septal exit versus lateral exit, will decide how much R wave you're going to have in lead 1 versus purely some of them will have a S wave. That demonstrates it's an exit from the lateral side of the posteromedial papillary muscle. So looking at the 12 lead ECGs, which can tell you whether this is going to be upward battle or not, first of all is precordial transition and notching, which are seen in inferior and precordial leads. Sorry, let me try and go like this. So when you look at the inferior leads, if you have a notching which is seen in these inferior lead or in the precordial leads, generally they are associated with scar, or these patients have some intramural scar which is present, and that just tells you that this can be unsuccessful or require multiple ablation lesions. In our study, and I'm going to present our data, later transition of the R wave to S wave was also associated with worse outcome and required multiple ablation rather than a single procedure success. When you see a variable exit, such as these, they're also a marker that there are preferential conduction which is present, and this might be difficult to get rid of. In a Holter, if you are seeing multiple QRS morphology, that again is a telltale sign that these are going to be difficult cases which will require multiple lesions, maybe even multiple procedure to be able to eliminate those. So when we looked at our data, and this was work I did it when I was in Penn with Dr. Marchelinsky's lab, we had 167 PVC cases. In fact, we had 130, and I've added 37 patients since I'm back in Australia in last 1 year. We have done so. We now have 167 papillary muscle cases, and we have put together, this has been ready for submission now. Basically, we looked at the different parameters which can tell us whether these are going to be successful or not. And we found that presence of wide QRS PVCs, multiple morphology seen at baseline, is a marker of failure for a single procedure drug-free outcome, and often those patients will require multiple ablations. Looking at the electrocardiographic parameters such as fixed coupling interval of the PVC with the preceding sinus rhythm is again a marker of success. If you have a fixed coupling interval, generally those patients do much better than a variable coupling interval patients, which might suggest that those patients have variable exit, and therefore it might be challenging to get rid of those PVCs. We also looked at our multiple procedure drug-free outcome, and similar results were found. We found that QRS width along with number of PVC morphologies, were short of coming significant here as well, were a marker of overall failure even after multiple procedures. So if you have varying morphology, if you have multiple morphology, generally they are a bad sign. Those patients generally will require multiple procedures rather than one procedure, and you unfortunately might still not be 100% successful. You might be able to suppress but not eliminate those PVCs. We then wanted to look at the electrocardiographic and electrophysiological parameters to see whether those parameters can predict success based on the location of PVC. So we looked at anterolateral papillary muscle and looking at the successful versus patients who required multiple procedures and were not successful at baseline. And what we found here, that width of the QRS and multiple PVC morphology remained as a significant predictor of success. Similarly, notching in the inferior and precordial leads were also predictor. That just tells us that there is a scar underlying in these PVCs as a mechanism behind these PVCs coming through, or there is a scar present and therefore it is difficult to try and eliminate those. Again, changing morphology at the time of ablation is also a significant predictor of outcome, again because of the variable exit. We look onto the posteromedial papillary muscle, the case which we are doing today. Exactly similar findings were seen in those as well. PVC QRS width, PVC morphology, presence of inferior lead notching, presence of precordial notching, and the changing morphology were all predictor of worse outcome for these patients. Changing gear from there, trying to highlight what is the importance of imaging in trying to plan these cases. It's extremely important. The use of multi-imaging modalities such as cardiac MRIs in conjunction with the real-time imaging data from intracardiac echoes can be extremely helpful to identify the size, the various shapes, and the origin of these PVC, and to understand and appreciate the underlying the substrate which might be responsible for these papillary muscles. So as you can understand, these papillary muscles can insert at different angles or a different part of the clock. If you think of this as a clock, it can be either 2 o'clock or 3 o'clock or 4 o'clock, and the ECG, what you see with these PVC, can be significantly different, and therefore having a cardiac MRI, you'll be able to understand where the location is, what type of structure it is. Is it a bifid or single conical, or is it a tethered type of papillary muscle? And then you can really plan your procedure based on the location and the type and the volume of that papillary muscle. Use of 3D imaging and integration is extremely important, and that's why I've been using CARTO and use of intracardiac echo to merge the CARTO sound image, and then use an activation map and pace map, as I personally have found to be really useful. When we deal with the scar-related papillary muscle cases, or that means if you have scar adjacent or confluent around the papillary muscle regions, we have been using music software from Bordeaux Group, where basically the use of CT and MRI, you'll be able to construct the scar. And this was a fantastic case where we found the channel and ablation around those areas. We were successful in eliminating those PVCs, which were really coming from that area. I'm saying we should try and incorporate different imaging modalities, different mapping modalities to try and make our life easy. Looking at the imaging characteristics from our cohort of patients, we found low ejection fraction, and dilatation of LV was a marker of worse outcome. Similarly, in cardiac MRI scan, we found arrhythmogenic pap muscle volume. So if you have a thick, chunky papillary muscle which has got scar, of course, it makes sense that those are going to be more difficult to try and eliminate. Quickly, just trying to address the right ventricle and what are the emanations we have. We should not shy away from using technology when you're trying to deal with these type of cases. Use of a long sheet such as Agilis is going to be extremely important to maintain the stability and the contact force in something which is moving. As we highlighted before, it is difficult because the structure is moving and you are trying to give an effective lesion, especially in these cases where you're finding difficult to try and have good stability, either use of a high voltage, so around to start with 30-40 watts rather than start with 25 and titrate up is going to be effective. Use of image integration is again important. And in those cases where you still find it challenging, use of cryo to try and have a good catheter stability. As you can see here, you are really struggling to try and maintain a catheter stability. Use of cryo, you're stuck there and you'll be able to provide an effective lesion in those cases. And of course, the case was successful. This has been accepted in JACC-EP, and which is going to be published in the next couple of months, where we had 17 cases where RF failed and we used cryo, and I'm going to show some of the data from that as well. Looking at the left ventricle, trying to come up with a plan for access. Again, different school of thought, but generally speaking, if your retrograde is excellent for posteromedial papillary muscle, whereas antegrade approach, which is transeptal approach, is excellent for anterolateral papillary muscle, in my experience, where you'll be able to try maintain good catheter stability and provide effective lesion in those cases. Use of, again, image integration is extremely important. It's very important to use force sensing catheter in these cases so that you can use directionality of the force sensing vector to understand the RF application, and the effective lesions can be delivered at the area of interest. Use of real-time imaging is again important, not only to understand the catheter stability, but also to watch for the echogenicity, because they can be prelude for a steam pop, especially if you are doing an RF ablation at the base of these papillary muscle where there is not much blood flow and you are at risk of having steep pop and LV perforation. I personally find use of intracardiac echo to watch for your lesion is extremely important. And finally, use of cryo in cases where the catheter stability still remains a problem. So we looked at our case series of 16 patients where we had to change from RF to cryo. There was nothing which tells me that one strategy is going to be more successful versus other. We found anterolateral, posteromedial, RV, antegrade, or transeptal, retrograde, different cases. There was nothing ECG-wise or location of the PVC which could tell you that you should use one type of energy delivery system over other. And my standard approach is generally to start with RF, and if you fail, then to go for cryo. I personally find using cryo large curve, you have a higher risk of aortic dissection, especially going retrograde aortic, and I personally try and use RF, especially smart touch, a D curve, prolapse, and then do. But sometime you will have to switch over to cryo if you are struggling and having difficulty in maintaining catheter stability. I will also try and touch base on a few other things, one of them being the PVC-induced ventricular fibrillation. Considering proximity to the conduction system, these are not infrequently seen, so ventricular fibrillation. So we looked at our data to see whether we can predict which PVC cases will have a higher risk of ventricular fibrillation. And what we found here is, again, the QRS width was a marker of increased risk of ventricular fibrillation. The most striking was wide variation in the coupling interval. So if your coupling interval for the PVC with the preceding R wave continues to change, of course, number one, it will have a variable exit. However, there's a likelihood of it falling into a critical part of QRS and leading to ventricular fibrillation. So that's one of the things. And finally, an imaging presence of scar was found to be significantly associated. More scars were seen in patients who had more ventricular fibrillation. I don't know how to use that as a marker for increased risk of ventricular fibrillation. Of course, those are diseased ventricle. Maybe that's why they have a higher risk of ventricular fibrillation. So in conclusion, ladies and gentlemen, ablation of papillary muscle PVC is safe and effective treatment strategy. This is the data which we have pulled together. As you can see, 41% of the patients, you'll be able to eliminate these PVC after single procedure, and they will remain drug-free, and our follow-up data was for 7 years. 21% of those patients will require multiple procedures. 27% of the patients, even after multiple procedures, will require some type of antiarrhythmic medication. However, that still is a success. These are the patients you're only taking into the lab once they have failed antiarrhythmic medication. If after multiple procedures with drug, you can contain the PVC, that still remains as, somewhat successful, and only 11% of those patients we failed, and these patients continue to have PVC. There are various challenging ablation of these PVCs are challenging. This reason being the origin may be located deep beneath the endocardium of these papillary muscle, and therefore difficult to get effective lesions. They have often multiple varying morphology due to preferential conduction, therefore challenging to map and ablate. Predictor of successful catheter ablation being single morphology, a fixed coupling interval, use of activation map and pace map should be done. Use of different technologies such as real-time imaging is important. A pre-procedural cardiac MRI to understand the morphology, the size, the shape is critical in this. Thank you very much for your attention.